go ahead and record, so try to keep the swearing to a minimum. And the reason I'm recording is a lot of people have trouble sleeping, and this training may be helpful. Going forward, you need that kind of help. I really appreciate you guys being volunteered to come to this training. And I would ask that you mute if you're not talking, but you're certainly welcome to ask questions and participate. So this training is focused on the best practice synthesis in clinical supervision. And I'm going to go ahead and mute folks. Oh, Dawn, can you mute folks if you're you have that capacity?
I was trying, but it seems it won't let me. I think maybe you have to make me.
I'm going to do that.
Okay.
All right.
I'll go through and I'll mute and I'll mind folks.
All right, making you. All right.
I got it now.
So this, the reason Rutgers was commissioned to put together this training on the best practice synthesis of clinical supervision was because there's a project underway, and it has a lot of names, but you'll hear it called the Clinical Formulary or the Recovery Formulary. And what it is an attempt to have all of the hospitals providing very similar programs of high quality that will be reviewed for outcomes and fidelity. And while doing that, to set about to try to support staff in ways that maybe the institutions haven't done previously. And you'll hear more about that idea. So the two goals are improve the quality of this set of programming and support staff in the process of doing that. And so what is this, the Clinical Formulary Project? It has these 6 steps, and you'll hear more about these as the training progresses. But the first step was to identify programs, 8 of them actually, small list of programs that would be in this formulary. I don't know if you ever heard of the term formulary, but it's often referred to as a medication formulary. So if you're with US Healthcare, for example, there's a certain number of medications that you can get as part of that insurance, and they call that the medication formulary. A clinical formulary is similar, but it's psychosocial programs that we're providing to address certain mental health needs. So the next slide, I'll show you the 8 programs. What we're doing is today through Wednesday is we're going to be looking at step 2. And this is the training in this, what I call a highly restorative form of clinical supervision, where we take the best practice elements of numerous models and we try to combine them. And the other steps we'll cover on our last day when we talk about implementation. But what we need to know is that we're going to be focused on this best practice clinical supervision. So here is that preliminary list for the clinical formulary. And you're probably familiar with most of these, or at least heard about them. The one I still don't know much about is New Jersey Smart Recovery, which is for drug and alcohol. And that's coming statewide as we speak. And the reason these 8 were chosen was because they were pretty much happening most places, not everywhere, but they lent themselves to rudimentary fidelity assessment and outcome assessment. But there's no magic to these particular ones. Some of them are what we would call evidence-based, including the first one, illness management recovery, is an evidence-based practice. And social skills for schizophrenia is also an evidence-based practice. And I think NJ Smart Recovery is also, at least has a growing evidence base. Oh, I should note, these would likely change. Some might get bumped over time. And here, other contenders are down here. The creative arts, art therapy and music therapy. I never knew this, but there's actually terrific evidence for the effectiveness of those programs in certain domains. Oh, and of course, the Why We Love Tom group. Who wouldn't want to participate? So the training agenda, today we're going to talk about the common factors of clinical supervision, meaning whatever model you study, they will have these same 3 common factors or functions. So that's what we're going to focus on today, including the science of clinical supervision. Then we're going to look at each of the functions over the next couple days. And lastly, on Wednesday, I think we'll have a short day. And we're going to talk about implementation and implementation science. Believe it or not, there is a science of implementation. I'm going to turn off my microphone because my own beauty is so distracting that there we go. All right, so specifically for today, I'm going to introduce this idea of called reference standards. You might know them also as fidelity standards, but it has to do with how clinical supervision works as a feedback loop. And so what we're feeding back are what we call the reference standards. Next, we're going to look at generic functions of clinical supervision, and there are 3 of them. And you'll be sick of hearing them, hopefully, by the end of the training, so it's, maybe they'll stick. And then if people stay awake, that would be a first for this training. So we'll see how that goes. If you do fall asleep, we're going to draw on your face with a Sharpie marker. That's what I usually do, put cat whiskers. All right, so one of the things I think is under discussed on treatment teams and within the hospital, and I wonder if people even know about it, and that is just how effective are psychosocial programs. In other words, not medications, but the kind of programs that the rehabilitation departments provide, as well as social work and really anybody who's doing a psychosocial programs. And so 2 of the large kind of repositories of evidence were studies that were commissioned by the federal government, and they're called the PORT 1 and then later PORT 2 studies. And PORT stands for the Patient Outcome Research Team Study, strange name. And they found what other large studies have found is that, in fact, psychosocial programs work surprisingly well, sometimes as well or better than medications, and they're often more lasting than medications alone. But the PORT studies also found what, unfortunately, we all know to be true, is so few of our clients and patients receive these programs, or if they receive them, they're often receiving a light version of them. In other words, what makes them work, they may not be getting to the client. So what do they do? Like, what are psychosocial programs actually doing? And I saw this recently in a large meta-analysis by a new love of mine. His name is Gary Burlingame, and he's just awesome. He's from out west. But he identified 2 types of clinical outcomes. The first one he called illness-specific outcomes. So the idea of reducing the positive and negative symptoms of schizophrenia, reducing depression, reducing anxiety. So it's targeted at the illness itself. But then the second type he described were program-specific outcomes. For example, if you're teaching a budgeting class, learning to budget is a program-specific outcome. It isn't necessarily related to the symptoms of the illness, although these, of course, overlap. Social skills is another one. Programs to reduce readmission, things like that. Feel free, if you have any questions or if you think I'm way off target, please put it in the chat. And Dawn Reinhardt Wood here is my technical person today, and she'll flag me and let me know that there's a question or rotten fruit on my way, whatever. All right, so illness-specific and program-specific. So let's look specifically at schizophrenia. There's very good evidence that even when folks have well-regulated, that they're on medication that's really working for them, about 60+% of folks still have residual symptoms that can be helped with these programs that I'm referring to, these psychosocial programs. So the old days of like just entertain people while they get the medications to work, just waste their time, not waste their time, but like bingo and stuff. Nothing wrong with that. But let's just do that until the meds work, and it's really the meds are the treatment. It turns out that that's inaccurate, and we're learning more and more about how to use these psychosocial programs in ways that can improve the person's trajectory of recovery. I'll give you some examples. In a large review, 52 studies, they found that these psychosocial groups can reduce the positive and negative symptoms. So these are the illness-specific outcomes are affected by psychosocial programs. You might not have thought that. I think that's fascinating. And I'll tell you what the G means in a second as we go forward. And it's a effect size. And then in the area of treatment-specific outcomes, those treatment-specific outcomes, like learning social skills, overlaps with the illness-specific outcomes. In other words, when somebody learns social skills or they learn something else in one of our groups, it helps reduce their positive and negative symptoms, right? Which is fascinating, because you think of the positive and negative symptoms as a biological consequence of the illness, and maybe it is. All right, I know this is kind of complicated, a little wonky, but I think it's helpful if I can get it across. All right, so 16% is explained by treatment-specific outcomes. There's an overlap. And that 44% of general functioning improvement is explained by these treatment-specific groups, like social skills. You'll be hearing about tools for moving on, illness management, recovery, things like that. So, all right, so maybe that's just people in the community, in community-based programs, and maybe our folks are too sick, right? It's a legitimate observation. Well, here in another large review, Costers et al., 70 studies found that psychosocial programs in inpatient settings were demonstrably effective. And here we see these effect sizes, which I'll tell you what those are in a second, compared to treatment as usual. And I think it was fascinating. In this review, people on the waiting list got worse. Because you might say, well, maybe people are just getting better because they're in the hospital and they're chilling and they're getting medication. But that was not the case in this large study. All right, bit of a nerd alert. Whoop, whoop. So what does this D or G mean when we talk about an effect size? And I know this is kind of complicated, but I think it's important. You see the blue is a normal curve, right? And say we're charting happiness on the x-axis on the bottom and a number of patients on the y-axis. When you see a D, so D is in terms of standard deviations. And so what you see is that the curve moves over, in our case here, if it's happiness, it's moving in the positive direction, one standard deviation. In other words, the whole thing shifts over. And it just pulls people along, meaning that when you see an effect size of 1 is very large, but the other ones were 0.5, it's a large effect, is my point. And it can have a real change in people's lives, depending on if it's anxiety or depression, which of course we want to be reduced. But that's what those Ds mean. It's the mean has moved that much of a standard deviation. So it could be 0.3, 0.4, 0.5 of a standard deviation of the curve. That'll be on the test, by the way. So I want to jot that down. Okay, so even if you've believed all the mumbo jumbo that I've been spouting so far, maybe that's not true of our particular system. Maybe our particular system is really bad. And we have problems no one else has, or maybe the people in our system are so much more sicker than everywhere else in the world. So we've done 4 studies, but more than 4, but these are the 4 I'll tell you about. The first one is on illness management and recovery. And we found that for every hour of that program that somebody attended, their risk of readmission was reduced by 1.1%. Now, admittedly, that's not a large number, 1.1%, but the average person received 12 hours. And so we're talking about 13% reduction in the risk of readmission. And so it appears we controlled for a lot of different things. We controlled for GA, global assessment of functioning, and attendance at other programs, and on and on. So that's very encouraging, suggesting that if people can tolerate IMR and if we can do it fairly well, we can help people stay out of the hospital. It's terrific. Moving to the right, there's a program called New Jersey Tamar. I forget what Tamar stands for. Dawn, any idea for $20? What does Tamar stand for?
I believe it is treatment, addiction, trauma, addiction, mental health and recovery, something along those lines. I'm not the Tamar person, so.
All right, we'll go with that. But anyway, it's a trauma program, and we did pre and post tests, and we found that on a measure of the effect of trauma on someone's life, a self-reported measure called the PCL5, that post-test scores dropped often below PTSD diagnostic levels. In other words, the person came in with a very high score that would be a preliminary diagnosis of PTSD, and it was reduced on the basis of the program or in association with the program. So that's also very exciting. This other program called Readiness Check-In at the bottom left is a program where staff outreach or reach out to people in the hospital who are not participating in programming or really participating in their own recovery. They're just kind of living in the hospital. And we found that clients that received this service attended more programs from pre to post and experienced swifter discharge, which was unexpected. That people in this program got out of the hospital sooner compared to people that were not in this program but had the same characteristics otherwise, which is very interesting. All right, the last one, hope I'm not boring you too much. A program called Tools for Moving On, which is a program to prepare people for tenancy, for living in the community. This program saw an increase in the measures of self-efficacy of 2.9 points across the board. So that was the mean change, suggesting that people felt like they were more prepared to live in the community, which is also very positive. And a lot of those folks didn't know what they didn't know, right? So they said, yeah, I'm ready to go. And then they start learning about, can you have an intimate partner sleep over, and, all these different issues that will come up when they're faced with tenancy. Dawn, do we have any questions or comments at this point?
No, sir. I just wanted to let the participants know that we're sending the PowerPoint deck out to them right now, so they'll be able to have it.
Also, Dawn, if you could, would you post our website?
Yes, I'll do that right now.
So for people who don't know, Rutgers runs a website for the state hospitals, and it has about 30 free trainings there with also a lot of other interesting information. And it's really designed for staff of the 4 hospitals of New Jersey. All right. So one of the interesting things I think we've all noticed, I suspect we've all noticed, is that the hospital systems have historically focused on outputs. In other words, how many groups are happening and how many people are in those groups and all that. And that's important. But really, it's much more important are the outcomes. And so if any of you have ever attended a program oversight committee, it's unlikely that people talked about anything but anecdotal outcomes. But there's been no formal attempt to determine whether the programs were effective for our clients. And that's one of the things this program is intended to change, is to see if we can see whether the programs are actually working. And if they're not working well, like, are there other programs out there, or what can we do to change? All right, so in any training of clinical supervision, the big challenge is that many folks think of supervision, when they think of it, they're thinking of administrative supervision and not clinical supervision. And so here's a definition of administrative supervision from a guy named Kadushin, I think. He says that administrative supervision is promotion and maintenance of good standards of work, following policies, assurance of a smooth running office, time, attendance, documentation. And so if you're receiving supervision and you're talking about documentation and attendance and things like that, that's administrative supervision. So here's my first challenge to you guys. Dun, dun, dun. What does the term clinical supervision mean? Whoop. What does the word clinical, I'll put it this way. What does the word clinical mean? Just type in the chat if you want, or if you want to unmute, tell us what you guys think. What does the term clinical mean? I have all day. I'll just sit here. Terry, good. What does clinical mean? Put her on the spot.
Melissa said it's working directly with the patients.
Nice. And that would be a difference from administrative supervision, like attendance and documentation. The focus is on working with the patients. I agree with that. What do other people think? I asked this like I know. I taught clinical principles in psych rehab for years, and I never knew what the term meant. So, yeah, I wouldn't feel so bad. Anybody else want to take a stab?
Supporting the treatment of the patients.
Nice.
Patients, so support, education.
Okay, supporting the treatment of the patients, education of the patients. So again, it's face-to-face, kind of with the patient. That's absolutely true. All right, let me show you what I looked up. So there was a bunch of definitions, but the one I like and I think applies is the application of objective and standardized methods to describing, evaluating, and modifying human behavior. So if you're doing a clinical intervention, say a behavioral intervention, you want to know the science of behaviorism. You want to know about reinforcement and extinguishing and that kind of thing. And that would constitute clinical. So it's really bringing to bear objective and standardized methods to helping our clients, right? As opposed to administrative. So let me just show you one pro tip. When we're doing clinical supervision, we want to bump administrative issues up to the leadership best we can. We don't get bogged down in administrative problems, because gosh knows there's a lot of administrative problems. Like just getting people to groups is a huge problem. All right, so this is the direction we're gonna go, is what are the objective and standardized methods? So if we hope to get those outcomes I was referring to earlier, what would we have to do? So I'm going to call these objective and standardized methods reference standards, meaning they're what we refer to know whether the group is a good group or maybe a not so good group, or it's hitting all the bells and whistles that we want it to. It's also known as treatment adherence or structured practice or programmatic fidelity. All refer to what is the standard of good practice that we're comparing to. So this is admittedly really complicated, and we're going to do a bit of an exercise. I recognize how complicated it is, but so any program, any clinical program can be deconstructed in a way to identify what things are prohibited, like what things should you not be doing, and what things are essential, like that you should definitely be doing. And what are those things in the middle that maybe are essential but not unique and compatible? So I put it in a what's that called? Pyramid. Starting at the bottom, you see things that are essential but not unique. And in the literature, this is referred to as common factors. And what we're going to do is we're going to break out. And what I'd like people to do is pick a practice and try to identify one of each type, one of A, one of B, one of C, and one of D. And Dawn is going to copy the previous slide. No, you can't. I have to do it. I'm going to copy the previous slide and put it in the chat. And we're going to send you guys to what's called a breakout room. I think. Yes, we are. All right. So the goal is to try to flesh this out. So say if you pick illness management recovery, what's essential to illness management recovery, but maybe not unique to it? So I think of empathy is essential to the treatment we do, but it's not unique to illness management recovery. You presumably would see that in every program. And then what's something that's compatible, but it's not necessary or unique. So like doing a collage to express your recovery goals is certainly compatible, but it may not be unique. You could do that in any group. That's kind of the idea. All right, so let me see if I can send you guys very briefly to a breakout room. And I'm going to try and put Dawn into one of them and me into the other, but we'll see what happens. And we're going to do 3 groups. Nope, then Dawn can't be in 2 groups. All right, so we're going to do 2 slightly large groups. So, and then I will put in the chat the 4 categories: essential but not unique, compatible but neither necessary nor unique, unique, essential, and prohibitive. Bear with me 1 second. All right. I'm just jumping all around. Well, I can't put it in the chat. So, Dawn, can you remember those? All right. So I'm going to do A, B, C, and D. I'll be in the one group, and Dawn will be in the other group. We'll see how we do. And this is super hard. I get it, but it's worth doing. All right. I'll see you in the breakout rooms. We're going to go for about 8 minutes because we've got plenty to cover. Pretty. Beverly, are you there? I think I wasn't able to send you. My-
Most,
Go ahead.
Dawn asked me to come back because most of the people are in her breakout room. She has about 18 people.
Okay.
So she thought maybe you might move some over to you.
I don't know how. Okay. All right, I can do it. I can do it. I think. All right. Break camera. Okay. Yeah, I think I was supposed to hit 2 when I hit 1. Ah, I got it. I know what to do. I'm
Yeah,
gonna
I come back.
Yeah.
Yeah, they're still having a conversation and everything, talking about it, but she thought it was a lot of people.
She's right. I think I should have hit 2 when I hit 1.
Here they come.
Yeah, I'm bringing them back. All right, that's about 7. Should I steal one more?
Yeah, her group is pretty large.
Okay. I stole Jackie Frazier too. Okay, guys, I brought some of you back. My mistake. I hit 1 when I hit it. Should have hit 2. I zigged when I should have zagged. All right, so let's pick a practice. What do you guys want to pick?
Compatible.
Okay, I mean not which one of those. What practice? Like social skills, tools for moving on, illness management recovery, social. Oh, I did it. MDLE. What do you think?
IMR is fine, I guess.
Yeah, that's great. All right, so what's essential but not unique to IMR? What are some examples? And turn your camera on if you can. You don't have to, but if you got it. So when you think of the kind of work we do, what's essential to the kind of work we do, but not unique to IMR? You can put it in the chat too if you don't have a mic. Beverly, what about you? What do you think? What's essential but not unique to IMR? Or really any program?
I think she's on mute. Might not know.
Oh, okay. Let me look.
Yeah.
I don't see a mute. No.
No, there's two Beverly Nelsons, so I don't know.
Oh, yeah, you're right.
Yeah, she might be having technical difficulties.
Oh, no worries. So I gave one example was empathy.
Mhm.
So trying to be empathetic is essential to the kind of work we do, but it's not unique to IMR. Are there any others? How about C. Jones? What do you think? I see something in the chat. Unmuting doesn't work. Oh, yeah, people are having trouble. How about you, Tricia? What do you think? What's essential but not unique?
Well, going along with empathy, just to have some type of, like in a group, you'd have group rules. You, regardless of the group, there'd be
So
have rules to abide by.
being respectful of other group members, one person at a time, things like, okay, that's good. So group rules. I never thought of that. That is good. How about other people? Is Jackie Frazier there? There's Jackie Frazier. Jackie, what do you think?
Can you hear me?
Yep.
Now I can.
Okay, you said empathy, being respectful, right?
Yeah.
What's unique to our job?
What's essential to
What's
doing
essential?
IMR, but not unique to doing IMR? Like you need it, but it's not unique to that practice.
Well, I mean, I'm kind of at a disadvantage because I haven't did IMR in a long.
Wow. But you've seen a lot of programs over the years, I'll bet.
Yeah, illness management, illness management recovery.
Yeah,
I'm
It could
having
be social
trouble.
skills. You know, it could be anything, really.
yeah.
Oh, we have something in the chat, Tom.
I'm throwing a blank. Building
okay.
support.
Nice. Being supported, building support. All right. Yep, building social
Go
support.
along with like being on time for the program. That would be essential, but not unique to just IMR or any program.
So I think you said it before, but like group rules, any kind of group management is essential, but not unique to IMR. But any group you do needs that. All right, let's jump to what's compatible. In other words, you can do it in IMR, but you don't have to. Any thoughts on that one? What's compatible, but not necessary or unique? I've got one. What about if, oh, go ahead.
I was wondering, do you mean as in activities? I
Yeah,
finally got
things
my
you
mic
might do in
working.
the group. Yeah,
Role play?
perfect. Absolutely. Yeah, I was going to say a field trip, like you go to the dollar store to address some of the issues in group, but it's not necessary, but you can certainly do it. That was good. Thank you. All right, let's jump to what is unique and essential to IMR. Now, admittedly, you have to kind of know the program.
Well, I would just say following the manualized program.
All right. So the manual is unique. Good. Anything else that people know is unique? I know this program really well. And one thing that I know is unique is you have to identify a recovery goal because that fuels the whole program. So if you don't do that, you're really not doing IMR. Anything else that if people know IMR, what else? We got the manual, we got you need a recovery goal. All right, well, let's jump to the last one is what is prohibited when you do IMR? What is it you're not allowed to do? And this comes along with $20,000 if you can identify one prohibited behavior. That's right, $20,000. All right, I'm going to go again. I think one thing I know that's prohibited in IMR is choosing somebody's goal for them. You're just not allowed to do that. And of course, things like shaming, trying to shame someone into recovery or guilt them into recovery, also prohibited in hopefully in all of our programs, but particularly IMR. Okay, so you get an idea of how you can deconstruct a program using this strategy. Now, it's really hard when you're just thrown at it, it's thrown at you the way I did. But in supervision, this can be really helpful if we know what's prohibited and you sit in on a group and you watch the staff do it. It's good feedback if you see them doing things that we shouldn't be doing. All right, I'm going to go bring people back or start bringing them back. All right, they're going to close in 58 seconds. So in the literature, they talk about one of the most helpful of these categories are the prohibited behaviors because in some ways, they really define, they really prevent people from hurting clients, right? So certain behaviors by staff can actually hurt and inhibit people's recovery. And we want to avoid that at all costs. All right, thank you guys for that. I apologize for the technical problems. This is not my forte. So I think people are going to start coming back right about now. Here they come. What Dawn, you couldn't do it, you couldn't do your group with 25 people in it? I don't understand.
I did it anyway.
I stole the cool ones back to my group.
Hey, I've been known to put 20 people in a 15-passenger van, so.
So listen, my apologies. When it said breakout rooms, I didn't realize I was putting everybody in one breakout room. I thought, oh, anyway, right. No excuses, Coyote. All right, so this exercise, as bumpy and difficult as it was, gives you some sense of how we can deconstruct a program and try to identify what makes the program unique and what it is we should be supervising toward, what reference standards we should be holding up. Okay, so I'm going to send out this PowerPoint slide deck. I'm not going to cover this, but there's a great deal of information in the literature on what are called common factors. And the common factors are what seems to make programs work regardless of the theory. And Carl Rogers was notorious. He had like unconditional positive regard, authenticity, presence, things that if we can do them, that alone can be very helpful for the people we work with. Honesty, gotta be a good one. All right, so that's what these are. And I go through and try to explore those various levels, A, B, C, and D. All right, but now I want to talk about this idea of clinical supervision, and is it the best way to promote clinical excellence? Maybe there are other ways, and we're going to look at some of the options for that. So what we're doing right now is option one. It's called the train and pray solution. And you may have heard of this, but it's the idea of we'll take somebody to a motivational interviewing training and then pray that they change their clinical behavior accordingly. And unfortunately, it does not work. There's very, very strong evidence that trainings don't change clinical behaviors. You really need practice and what's called audit and feedback, which we'll talk more about. But you need somebody to watch what you're doing that knows the reference standard and offers feedback. So judging from this training is not going to change you. That's right. All right, so the next option is just telling the person what to do using an administrative approach to supervision. And I think we've all seen this in the state hospital system. It's called transactional leadership, where somebody just tells someone else what to do. And this type of leadership does work with certain changes. They call them stroke of the pen changes, like stop using this form, use this form, that kind of thing. But it doesn't work with things like motivational interviewing or complex clinical behaviors. It's just insufficient. Then we have my old boss, Joe Berkman, coined this term, the Chekhov syndrome. And I thought it was this guy, but apparently it's not. But you've seen many programs where there's a checklist, the nurse or somebody is checking off, looking for certain things. And this has often is ineffective simply because it doesn't get out at the complexity of the behaviors that we're looking for. This one, clinical experience, the chair of my department at Rutgers wrote a piece in a textbook. It was called "Experience is Not the Best Teacher." And it was just a slew of evidence where people had been in the field for a long time and did not get better at the kind of work they were doing. And in fact, they may have been stuck doing exactly what they did in their graduate program when they were originally trained. In other words, they didn't keep pace. People have heard of Dr. Cotton and the Cotton Award at Trenton Psychiatric Hospital. He apparently was removing gonads and doing a bunch of things that were later found not to be helpful. But apparently was a very caring individual, which is why they have the, it wasn't ill-intended when he did it. Some of the evidence that clinicians suffer from this thing called the clinician's illusion, where they only see people when they're at their sickest, and so they often don't see people when they recover. And this could be the explanation for why the field of psychology and psychiatry did not know that people recovered from schizophrenia because those people that recovered left their sample and they just kept seeing the clinical sample, which is the folks that are very ill. But we now know that a large number of people recover from schizophrenia. Whoops, sorry. So this last one, I've seen this over time, and it's the idea of deferring to somebody with credentials. And my previous boss called this the private practice model, meaning if you hire a psychologist, you expect that the psychologist will provide something really good, and they do whatever, the psychologist does whatever they see fit. And of course, the problem with this is they might be doing something that's evidence-based, but they might not. Or they might be stuck in the past. That can happen. So now there's considerable evidence that certain interventions, and I showed you some of the evidence at the beginning, when we do things to fidelity, in other words, we follow the reference standards, we can produce good outcomes, dependably good outcomes, which is really key to the kind of work we do. All right, I'm just going to take a quick jaunt into the history of clinical supervision. And this comes from Carol Yedich in 2000. And she described clinical supervision as starting to, as a way to support nurses in their very difficult work with medically ill people. And these nurses were often under the thumb of a male doctor, at least at the time of historically. And so it was intended to support the nurses, right? And Yedich describes this changing when this woman, Beverly Allett, was accused of killing young, very disabled patients in an institution. And a commission was formed called the Allett Commission. And the commission said, how could this happen? Who was supervising? Who was overseeing what Allett was doing? And it marked a sea change in England of clinical supervision, moving from support to scrutiny, right? And many of you may still think of supervision as scrutiny, that, you know, and not a good thing. And so what this training, what I'm going to be pitching is that we move back to support as the foundation of our clinical supervision and our administrative supervision for that matter. All right, so this guy Watkins did a review over 25 years of clinical supervision, and he identified a huge movement towards the use of evidence-based practices. You've heard me talk about them today. And that's the idea that there's evidence that certain programs done in a particular way produce reliable, positive outcomes, which is really exciting. And we need to capitalize on that, right? We don't want to continue to do things that are less effective if there's better things out there. He found a clear evidence for staff benefits from clinical supervision. He found some evidence that there's skill transfer from the supervisor to the supervisee, but he found little evidence of improved client outcomes. And one of the criticisms of this review, he called it the gold standard. If we don't show that clinical supervision improves client outcomes, you know, is it worth it? And one of the criticisms of this review is that what the supervision wasn't clearly defined. In other words, everybody defines clinical supervision differently. And whoa, look at that. So I'm just going to skip a few slides. So these slides are actually slides. This one's has a blue ladder and a red sliding board, one of my favorites. Green. Very princess-like, sort of. So anyway, so why do clinical supervision? If Watkins is right and we can't demonstrate that it improves clinical outcomes with clients, why should we do it? And well, it turns out that even by Watkins standards, the latest research has found that certain interventions, when supervised in a particular way, do show improved client outcomes. Now, this is pretty new, and it's not every program. But so that's one reason to do it. Some other reasons are supervision been shown to improve staff satisfaction, reduce stress for staff, improve accountability, and improve knowledge. It's also been shown to increase self-awareness. You can read skill acquisition, a lot of good stuff. And it's been identified as essential to patient practitioner safety, right? So it also does serve as an accountability check. All right. So there's a huge number of models of clinical supervision, which is why we're doing a synthesis today and not focused on just on one model. One model is called isomorphic, which is you use the clinical intervention as the model for the supervision. So if you're doing cognitive behavioral therapy, you would use a cognitive behavioral approach in that supervision and parallel it. And I'm going to finish up this soon. I know this is a long introduction to clinical supervision, but so this guy Derek Milne is one of the primary researchers in clinical supervision, and he's identified that the huge number of models, there's literally hundreds of models of clinical supervision, are strong on imagination but worryingly weak when subjected to careful examination, and that's certainly been my experience. All right, so we're going to skip some of this stuff. And you'll get this slide deck if you're interested in learning a little more about that. So here's his definition. He says clinical supervision is the formal provision. So it's not happening in the hallway as you walk by. It's a thing that we do together periodically by approved supervisors. Poof, you're all approved now that you've come to this training. Of a relationship-based education and training, and it's work-focused and manages, supports, and develops and evaluates the work of colleagues. That's a mouthful. But then he goes on to clarify that the main method is corrective feedback based on the reference standards. And because of this evaluation component, this corrective feedback component, it differs from related activities such as mentoring, coaching, because it's evaluative. So if you've ever wondered what's the difference between mentoring, coaching, and clinical supervision, it's the presence of an evaluative component, at least according to Derek Milne. Milne goes on to identify normative, restorative, and formative as the three objectives of clinical supervision. So I'm going to change the order, but let's call it restorative, normative, formative. Let's all say that with me at home. Restorative, formative, normative. Is everybody saying it? Restorative, formative, normative. It's going to be on the test. I know that's a lot of words for a slide, my apologies. So restorative, formative, normative. So the rest of the supervision is how do we accomplish these three functions to be restorative, be formative, and be normative? I'm going to define them for you. Interestingly, in 1976, this guy, Alfred Kadushin, who was a social worker, and he wrote a textbook that's still used today in 25th edition or something. But he identified administrative, educational, and supportive, and they are the same categories, but they don't rhyme, so he's out of luck. So we're going to go with restorative, formative, and normative. We're going to take a break in just a minute. I know there's a lot of information. So I used to think that the three objectives of clinical supervision were equal. I've now come to realize that the restorative function is the primary focus of clinical supervision. It has to be. And it's the thing that makes it safe enough to do the kind of work that we want to do well. And it's what allows us to stay healthy and do this kind of work over the long term. And we're going to break out these in some detail going forward. So what is the restorative function? It's supportive. It promotes reflective practice, emotional processing. It includes team building. It's the main weapon against staff burnout, which I'll talk about coming up. So it's really, really important. And if we accomplish nothing else but support the staff and have staff reduce their chance of burnout, I think we've accomplished a lot. The formative function, just think of forming new skills, formative. this has all to do with clinical competencies, knowledge, skills, and attitudes to do the kind of complex clinical work that will produce these results. The main tool for the formative function is something called audit and feedback, and we'll spend some time. But this has an enormous amount of evidence supporting it, and it's the idea of really observing somebody doing a practice and offering them supportive feedback, constructive feedback. And lastly, the normative function is accountability, right? And you can't escape the need for this, but it's to make sure that people are staying in line with our ethics and norms and not hurting anyone. But it's also that we're in line with the evidence of effectiveness. So if you're doing screen therapy with people with schizophrenia, you better be clear that there's evidence that that's helpful and not harmful. Anybody doing screen therapy, by the way? Just raise your hand. No? No screen therapy. All right. And this that's really the last slide for this section. And it's the idea that the restorative function is really supportive. It's intended to be supportive, and it's an opportunity for people to reflect on how they're feeling and how they're doing, and self-care and team care, teams taking care of one another. And it's in tension with accountability, right? So you want a person to feel safe in the clinical supervision, psychologically safe, but at the same time, you want to hold them accountable for really good clinical work and ethical work. And there is a tension there, and that's why you get the big bucks being a supervisor. All right, so we're going to take, let's come back at 10 after, which is 2:10. Go take a break, get a glass of water, and come back, and then we're going to finish this up going forwards to 3 o'clock. So we'll come back at 10 after. Thanks. Okay, it's 10 after and get started again. So at this point, we're gonna move on to looking at the various functions of clinical supervision that I mentioned. And we're gonna start with restorative. And as you can see, the next one will be formative, then normative, and then we're gonna talk about implementation. So we're gonna look at something that in the world of industrial psychology, they call emotional labor. You'll know it as your job. Many of your job, it's the interface with clients. And then we're going to describe two activities that can serve as restorative interventions for clinical supervision. So how do you do this? How do you accomplish this restorative function of supporting staff? That's what we're going to address. And we're going to start by doing something that we would actually do all the time in the various clinical supervisions that use this approach. And that is identify self-care strategies. So it's not all about self-care. We certainly have an obligation to one another, and the organization has an obligation to support us. But it's also really helpful if we have strategies that work for us that we can share with other people. So I'd like to just open up the floor. You can use the chat function or you can jump in on your mic. Let's do the purple one. What's one self-care strategy that helps you at home? What's a self-care strategy that you use at home that you find helps you stay well? I'll give you an example. I run just about every day. I've slowed down to the point where people think I'm walking, but I'm actually running. But that's been invaluable for me to stay healthy. How about other people? What do you guys do?
So some folks are saying exercise, similar to what you said, Tom. Self-reflection was said by another individual. Spa day, I like that one.
Nice. I'll be at your house later.
Tom's house is like a resort, by the way, guys. We could all go there for a spa day.
Hey now.
Fussing over my plants.
Nice.
I like that one. So I fuss over my cat. Some of you saw she made an appearance today. So that's mine. Terry said walking.
Nice. So a lot of physical activities. Anybody do yoga out there or meditate?
One lone meditator for yoga.
Nice.
Luis also said pray. Ivy is a yogi.
Nice.
Nice.
Not a yogi bear, but a yogi like.
Oh, she's not.
All right. Anybody else? So this is something we might do. We might just do a round in the clinical supervision to start off and just say like how, what kind of self-care strategies have people used in the last week or since the last supervision? And if people are kind of feeling like they're not doing well in this area, are they willing to make a commitment to trying something either new or getting back to something that has worked in the past? All right, so let's flip now and look at what's one self-care strategy that people do at work. What's a self-care strategy people do at work? I'll give an example. I have a really good chair, super supportive, and I have a pillow, and I sit up. I try to sit up because my back is an absolute mess. So that's a main self-care strategy for me. How about you guys?
So I'm seeing take a walk on a lunch break, fresh air, deep breathing, chair stretches, fresh air. I'll say for me, the stretches and talking to coworkers is a helpful thing. Tessa says, go and greet others, especially during COVID.
I remember years ago, I used to not drink water to the point where I felt kind of faint. And so I've tried to remedy that. Anything else people do at work?
It looks like Jen Palmer says jazz music, cup of tea, actually taking the lunchtime. I think we should not ignore that. That's so important, and so many folks just work right on through. Tricia says stretching, taking the time to take a break, lunch, walking around, hydrating, deep breathing. And finally, Ivy says finding ways to laugh.
Very nice. That's terrific. Now, if I were to ask, could anyone improve, to feel like there's room for improvement? I'm guessing, like me, the answer would be absolutely yes. And so one of the things we'll do in clinical supervision is keep reminding ourselves that we got to sharpen the saw, and we're the saw, right? So we're going to be as good as we take care of ourselves, right? We're necessary in this equation. Okay, so this just gives an initial example of how we can start to put the light on staff support and taking care of ourselves. And this is specifically in the area of self-care, but there's others, of course. So as I mentioned, restorative, formative, normative are these three meta functions. They're really in virtually every model of clinical supervision. And when you don't see them, it's because the model is focused almost entirely on one or more, or one or two of them. But the literature suggests that they're all necessary. We looked at this slide before, but it's important to note this idea of reflective practice. The notion that one of the ways we're going to get better at being clinicians is if we reflect on what it is we're doing and should be doing, and what are the goals we have in order to get better at the work we do. And we need to know those reference standards in order to have a point of comparison, to know what it means to get better and better and better. Interesting thought exercise. I'm curious if anyone has ever known somebody in the state hospital system that has been there for 20 years, 25 years, 30 years, and they just really stink at what they do. Anybody like that? Does anybody know of somebody that's been around just maybe too long, really long time? And it could be that they were very good at one time and they burnt out, or it could be that they've always struggled. Maybe they never should have been in the field. But hopefully reflective practice would be one way into looking at that. So here's something, maybe it's provocative to some people, but it's my opinion, and that organizations have a duty to protect their workers. It's certainly true in the area of physical work, like, and I think we have a slide coming up about that. But in the area of emotional labor, which is a term, as I mentioned, I found in industrial psychology, and it's the idea that some people's jobs require that they be in a particular emotional place a lot. Like if you're a therapist, you don't have the option of freaking out at people and yelling at people and just being really angry or sullen or come across as depressed or whatever. The expectation is you're going to be there for the other person and be attentive and empathetic and all those common factors we mentioned. And so what are the dangers of this kind of work if that's the expectation? And I'm sure you've heard of many of these, obviously the high stress, but doing this kind of work and not getting enough support can really lead to all kinds of terrible outcomes. And sometimes the work just confronts us with really sad and traumatic stories and experiences, which can take their toll over time. And so if we're not doing the work of self-care and taking care of one another, we really could be in danger. So what is one of the umbrella terms is burnout. And burnout, at least Christina Maslach's conceptualization of burnout, is that it's three different things, and they actually progress from one to the next. What she says is, and Christina Maslach is the Maslach burnout inventory is her, and she may be the world's foremost authority on burnout. But she said the first thing that happens is a feeling of exhaustion, and particularly emotional exhaustion, where you just are like, oh my God, I can't take another thing. And of course, we work with patients who have like almost unceasing needs. And so it's understandable if people feel exhausted. But over time, if we're not replenished, that emotional exhaustion can lead to a desire to protect ourselves from further withdrawals, from further demands. And she called this depersonalization. She used to call it cynicism, but depersonalization is the idea like, I just can't take it anymore. And here's where you can start to see staff being rude to patients or just shutting patients down, or sometimes they shut down coworkers, and treat those around them like they're not real people in a way, which is the depersonalization. And then lastly, the syndrome is kind of complete when the staff person recognizes that they're just not as good at doing what they were doing anymore, and they feel this sense of reduced ability, reduced outcomes. So, like so many terms, burnout can be overused. Like I can say, I'm so burnt out with this television show, or I'm burnt out with it. What Maslach is talking about is really a syndrome of prolonged emotional exhaustion and leading to depersonalization and reduced effectiveness. And why is this so important? Well, it's been so well studied, and it's just terrible that a person may not realize that the feelings they're having at home can be associated with emotional exhaustion that they're experiencing at work. And so what do you see? Burnout, when measured by the Maslach burnout inventory, is associated with increased verbal and physical assaults at work. So think about that. When somebody's burnt out, they're verbally assaulted and physically assaulted more. Not to blame the staff person, but it's just a very interesting correlation. You see a reduced quality of professional work, which fits. Reduced job satisfaction, yep. Breaches in ethical conduct, lower productivity, increased in physical and mental health related problems. So we see anxiety and depression and drug and alcohol use. We see a negative contagion effect on colleagues, right? So if somebody on your team is experiencing burnout, they're likely hard to be around because they're really in a pretty dark place. And I don't even blame them. I feel like they're a victim of what they're going through. And then lastly, a negative spillover effect on home life. I mentioned this, you see more domestic abuse and drugs and alcohol. So burnout is terrible, pretty mildly. So my colleagues and I did a large study in New Jersey, and we found that 22% of clinical staff rated high in burnout, and 34% of support staff, which was really fascinating. We didn't anticipate this. And this is particularly in the emotional exhaustion domain of burnout. So I guess you could see 22% of clinical staff as like a good thing. It's not 100%, it's not 80%, but it's also 22% of the people we're working with are in danger and maybe already suffering some of the negative effects of burnout. The other thing we found in our study was something we call the golden handcuffs, and that's that more senior staff may be experiencing burnout, but they can't leave their job because it's too costly because of the benefits, and they couldn't make up what they would lose if they went on to another position somewhere else. So we call it the golden handcuffs. It's like you can understand the pickle they're in. So this is my mother's quote: "The plumber's pipes are always leaking," and her father, my grandfather, was a plumber, so she knows what she's talking about. And what this means is we're all trained in the provision of mental health services, and many of us got into this work because we are very empathetic and caring. But it's been my experience that we're often not that good with ourselves. I was impressed with the number and type and range of self-care activities. I think that's really, really great and hopeful. So this hypothesis, thing called the buffering hypothesis, comes from a large school of research from a guy named Karasek. And Karasek found that burnout can be predicted. And the way you predict it is if you have a job with high demands, low control, and low support. It's called the demand control support model. So high demands, low control, and low support inevitably leads to negative consequences. It could be physical consequences, you blow your back out, or it could be mental health consequences, as we've been describing. And so along with the demand control support model is this buffering hypothesis, which what if we increased organizational support? Could we buffer the high demands and low control, which sometimes you can't always change? So high demands, you understand, you have a lot to do. Low control is the things you have to do, you just have to do them. You don't have a lot of choice. So imagine Lucille Ball on the conveyor belt, eating the chocolates and they just keep coming. That's low control right there, and high demands. All right, so this job demand control support model has been studied for 30 years. And the final meta-analysis, the author wrote, we don't have to study this anymore. This is how you do it. High demands, low control, low support, and you'll hurt your staff. It's just it's a design problem. And so we should be aware of that and take steps. So this whole project to encourage the use of clinical supervision, restorative clinical supervision, is an effort to provide an organizational support to people so that they have more in the tank to provide to patients, and so that they love their jobs and are fun to be around. So as the first, that slide about, how do you take care of yourself at work? How do you take care of yourself at home? Would note there is a balance. Like sometimes people are miserable at work because they're miserable at home, and it's not the hospital's job to do therapy with people. It's all of our job to take care of ourselves. But we also don't want to set up jobs that are unreasonable and undoable. So what is the supervisor's role? Like, we're not therapists, but the research says that we can encourage personal and professional self-care. We started talking about that. We can provide information, which I'm trying to do. We can try to promote support from other people. And so in the clinical supervision, if we're doing group clinical supervision, we can encourage people to take care of one another. And sometimes it's instrumental support, where it's like, I'll cover that group for you. I can see you're having a hard time. And we've seen that. We've been doing experimenting with this type of supervision at Trenton Psychiatric Hospital and elsewhere. And we've absolutely seen this supportive group develop over time. And lastly, encouraging open discussions about vulnerability. So the idea of like, here's what I'm struggling with. I'm far from perfect. When it comes to the reference standards, even I don't even know what they are all the time, right? And so going in with an attitude of trying to learn as opposed to trying to be the expert is what I would encourage. So I kind of skipped the earlier pro tips, but they'll come in the slide deck. This one I won't skip. And it comes from, I was reading in the area of compassion and empathy. And I came across this idea that if supervisors are willing to be vulnerable about the fact that they have struggles, you're not trying to meet your needs through your subordinates or people you supervise. But if you're willing to be vulnerable, it can create trust in the group. I used to think that if the group had trust, that the people would be willing to be vulnerable. But at least in this series of articles I was reading, it is when somebody's willing to be vulnerable in the group, it creates trust in the group, which I thought was fascinating and pretty helpful. Okay, so I'm going to give you some practical strategies for achieving the restorative function of the group in group supervision. And I love some of it. I love many of these. The first one I really, really like. I learned about it just a few months ago from a colleague. And there's a slide on it coming up. But we're just going to briefly review these approaches. Here's the one takeaway point. There's no right way to promote restorative supervision or restoration or self-care or any of that, or reflective practice. It's really, the idea is that we try to do it and we keep trying. And that's what's really key. These are things we've used and we've had a lot of success. So we encourage you to use them, but you certainly don't have to. All right, so what is the PERMA model? I don't know if people know Martin Seligman, but he's the father of positive psychology. And positive psychology is a study of what makes people well and happy and feel like they have meaning in their life, as opposed to traditional psychology is the study of illness and what makes people ill. So Seligman has been working on this for years and years, and he has recently developed this, what he calls the PERMA model. And it's the idea that exploring with people what promotes positive emotion can be really helpful to help them be aware and reflect on, like, oh, right, this, listening to this kind of music really lends to positive emotion. I'm going to do that more. Same thing with what makes you feel engaged in your life. What kind of relationships make you feel well and happy and joyful? What brings meaning? What helps you experience meaning in your life? And what makes you feel accomplished in your life? So let's just do a quick round. And we can't do all of them. We don't have the time. But what's something that at work leads you to have positive emotion? When do you experience positive emotion at work?
And don't say when it's time to go home.
Oh, that's, you can say that if it's true, I guess. I'll tell you, for me, positive emotion, I mean, it's gonna, little disclosing, I suppose, but when I do some academic project and I get positive feedback about it, that people say, oh, this is really interesting, I learned something, I feel a sense of positive emotion when that happens. How about other?
So Luis said a patient's success.
Nice. So when you see a patient do well, you feel a positive emotion.
Melissa said something similar to what you said, Tom, when a colleague, specifically a member of their treatment team, takes her recommendations into account and remarks that it was valuable. So like that she's contributing to success. Jen Palmer said laughing about negative events that someone got through. So like making light about something or turning it into a positive light.
Nice.
Team potlucks, Ivy said.
Nice. So being with, I bet it's being with the team. I'm sure the food helps, but I'm assuming it's being with peers and team members. Anything else?
Tessa says when you make changes and there is reception by the team.
Nice.
And also when a difficult task is completed as a team. So that teamwork keeps coming up, it looks like.
Nice, nice, nice. So let's jump to the second one, because I feel like it's so helpful to have these kind of conversations and to reflect on it. Just in terms of engagement, I don't know if everybody ever heard of the book Flow, but there was, I can't say his name, I think it's Polish, or, but a book was written about things that you feel just completely engaged in and that you lose the sense of time. And I'm curious, do people have things in their life that they get so engaged in that they maybe do lose a sense of time and they feel just kind of in that activity, whatever it is? And I certainly feel that with running, that I often, at the end of my run, I'm like, wow, I really remember it. I was kind of so into it. Are there things in your life, not necessarily at work, but are there things in your life that you feel completely engaged in and you just get absorbed?
Melissa says hiking. Judy says a good book.
Nice. Anything else that people get engaged in, they get completely sucked in? So food for thought. According to Seligman, if we're focusing on these perma areas and really cultivating them and talking about them, we're going to be happier and feel more well. So I think that's very optimistic and worth doing. And so these are the kind of things. Now we wouldn't spend the entire supervision. We're going to do a number of restorative components in each supervision, but we're also going to talk about formative stuff about how do we address certain problems we're having in providing programming and learning some of the best practices about the various programs. But this is a big part of it. I would say this 50% is focusing on our own wellness and what we need to do this job. Okay, so this one is called the Chaos Inventory. And it was a colleague of mine showed me a scale, which was literally an inventory. And I don't use the scale or the paper, but just the idea that when we're under stress, it often shows up in our life in a variety of ways. It could be that your back hurts, your neck hurts, or it could be that your house is messy or your house is super clean. It could be that you start smoking or you start eating a lot or you stop eating or you stop sleeping or you see where I'm going with this. So let's do a quick round about this one. When you're under a lot of stress, I can't imagine that during COVID anybody would be under stress, but how does it show up in your life? I just smoked a cigar before this training, which I don't normally do. But this one way it shows up in my life is I smoke cigars, and I'm sure there are healthier outlets. How about you guys? Anybody have an incredibly clean house because when you're stressed, you clean? Or what is it for you?
So Tom, you mentioned it. Stress for me is like the best weight loss plan. So I can drop 20 pounds in a few weeks if I'm extremely stressed. So yeah, so it's like the pile up in the apartment in terms of getting messy and not eating. Yeah. Renee says she wishes she had the problem that it gets.
I know.
She's
I
more
think the
stressed.
same thing. I have exactly the opposite problem.
Need more quiet time, disconnection from reality are a couple others.
Yeah. So you see that need more and more as part of your chaos inventory. Yeah, that same colleague who gave me this, he said his car, it's like a bomb went off in his car when he's under stress. It's the last thing he does, he addresses. And so it shows up there.
Melissa says she notices a shorter fuse.
Yeah.
That's
I mean,
a day with a 13-year-old boy, by the way, short fuse.
yeah.
You're the mother of a 13-year-old.
So I don't know if people can see behind me, but I'm in my laboratory and I tidy when I'm under stress. So I've got a pretty tidy workshop there behind me. Let me turn that off. Okay, so you get the idea, but it's just another example of getting people to be willing to talk about being vulnerable and sharing things they wouldn't normally share, but that sharing can build strong teams and trusting teams. Now, there is a limit, right? That it's not therapy, and so we all have to recognize that it's an opportunity to be together and support one another, but of course there are limits and boundaries. Okay, next thing is an activity called mindfulness, and in Canada, they've been studying mindfulness in Toronto, and they describe it as mindfulness is an awareness of the current moment without judgment. That's their definition. But I really like this. And we can do anything. We can employ this strategy of being aware without judgment to our breathing, to eating, stretching, anything. I put pooping. My wife thought that was horrible, but you could do that, I suppose. And if you go to our website, and I think Dawn put it in the chat, or will if she hasn't, our website has a lot of mindfulness activities that Dr. Michelle Gallietta gave us, and she's the consultant around the dialectical behavioral therapy in the hospital system. But they're terrific. So I always wondered, like, why is mindfulness restorative? So the idea of being aware of the current moment without judgment, certainly just allowing yourself to be whoever, be and think whatever you want without judging that is certainly helpful. But it's also can be a linking skill. And I was taught this by Dr. Michael Giantini years ago. And I was saying that I was working with some clients and they learned social skills like way too fast. I couldn't get, because it says it takes about 6 weeks for people to learn this particular type of skill, these skills. And he said, Tom, it's a linking skill that you have to know when to employ the skill. You have to be aware enough to know when to do those self-care activities that we were identifying earlier. And so I think the reason one big reason mindfulness can be so restorative is that it can slow us down enough to determine what it is we need to do to take care of ourselves. What do we need? A colleague at Rutgers made these flashcards for patients, and they say, catch it, check it, change it. And it's catch your negative thoughts, check your thoughts, and change them if they're not serving you, which I loved it. And she's actually been studying it, and it's been shown to be really helpful. So we can do mindfulness activities in the clinical supervision as part of the restorative function and meeting the restorative function. Another activity we do is, of course, we don't do all of these every session, obviously, right? But these are all, perfectly fine to try to attend to the restorative function. We do a burnout meter, and it's just from 0 to 10. How burnout are you today? And now this is referring to burnout not as the constellation of long-term problems, but really the oh my God, it's been a really difficult day. And so we just ask on a scale of 1 to 10, how are you feeling today? 10 being like I'm about to explode, and 0 is I'm really doing fine. And we've been using this for a long time, and often people will say 8 or 9 or 10, and we take time to really explore with them. How what might be helpful. Have you give them an opportunity to sometimes just talk about it, or sometimes problem solve. People have really appreciated this in the past. And I haven't done this in a while, but we have done a bunch of team building exercises. They seem better when you're just getting started with setting up a clinical supervision. But we've done this thing where you introduce, have people interview one another, and then one introduces the other. And here are some questions we've asked. We did this at Raycroft at Trenton Psychiatric Hospital, and people approached me afterwards and said, I worked with some of these people for years, and I never knew anything about them other than professionally. They just didn't have opportunities to be real people. It was really, it's a professional setting, of course. But they found out that, many of them were gardeners, and many of them were into cooking. And so it did build the team. And it was really easy to do, which and fairly quick, worth doing. Okay, and we already did a self-care round in a way. We can do it a little more intensively. I was doing a training at Rutgers, and a psychologist said to me, well, we all know that we need at least as much care taking as our clients. And I was like, because it just seemed like nobody has ever cared for me as much as I've tried to care for my clients. But that was a lesson learned, right? That we really need it. Everybody does. And of course, if people feel like they're weak in this area, or they're just really not doing well, we encourage them to use the group as an accountability group, accountability buddy, and make a commitment, like I'm going to read 3 nights this week, or I'm going to go for a walk, or I'm going to go for a run, or whatever the activity they decide, or I'm going to start a new activity. Yeah, I know. It's silly, but it just makes me smile. Yep. All right. So had a bunch of pro tips. I've been studying clinical supervision a long time and doing it, trying to get better at it. And the first pro tip is don't slog through the administrative issues, particularly if they're not in your sphere of influence. Like if you can't control something, there's no sense in belaboring it. You want to bump it up to levels of leadership that could influence, and maybe they won't, but I've just spent too many clinical supervisions stuck talking about getting patients to groups, which is of course critically important. All right, second pro tip, if possible, separate the supportive, the restorative function and the accountability function. So it's my recommendation, and the way this project is set up, that the heads of rehab are, for the most part, not going to be the clinical supervisors of the groups. And it's the idea of trying to identify a clinical supervisor who's not also your administrative supervisor. Now, sometimes you can't do this, it's not reasonable, or the organization's too small. But if you can do it, it's just so much easier to be able to really focus on the restorative thing without an overwhelming focus on accountability, which is also important. And then lastly, our almost second to lastly, vulnerability creates trust. So if as supervisors, you're willing to be vulnerable, you can likely create a trusting group. And of course, we have to maintain boundaries, absolutely. But if you're willing, that's one way. It'd be very helpful. And of course, the bonus tip, supervisors need support too. And so you'll hear about an effort, we call it meta supervision, which just says supervision for supervisors. And it's a blast. I mean, I've really, really enjoyed that. It's one of the best professional experiences I've had. And it's just an opportunity for supervisors to talk about their stressors and what they need to do the job well, and best practices in supervision, that kind of thing. Okay, so that's all we have for today. We're going to meet again at 1 o'clock tomorrow. And tomorrow we're going to cover the formative function of clinical supervision and the normative function. So I hope to see you all then. If you want to bring me candy, that would be super. I'd really appreciate it, but you don't have to. Any questions or comments before we go? Some of the big takeaways I think are really important. What you do works. When you provide groups, it works. We should be in the job of supporting our staff best we can, emotionally supporting them, and otherwise. And there's plenty we can do. So I'll see you guys all tomorrow, 1 o'clock. I really appreciate you spending the time with me. See you then.
Good day.